Hello, everybody. It's good to see everyone here. Um, my name is Abhishek Reddy, and I'm an assistant professor at Virginia Tech Caribbean School of Medicine. I'm the Department of Psychiatry and Child Psychiatry. Um, so I'm just going to talk about uh, chalk talks today. Now, I'm still an early career psychiatrist, and so there's a lot to learn, obviously. Uh, I have no financial disclosures, and also I have a disclosure that I'm not an expert in the field of either chalk talks or teachings. I do have a couple of teach nominations before, but um, I'm not higher up in the med school teaching. But I then y'all would be probably wondering, hey, then why is this guy talking about chalk talks? Um, and what's the goal of this session, right? So this started when I was doing my promotion feedback with Dr. Harrent, and she came to one of the in-person chalk talks on our unit, and she suggested that, hey, I think your interactive chalk talk was good, and it might be beneficial if you could give some inputs to other team members. And I thought, okay, that sounds like a great idea, and I really appreciate Dr. Harrent encouraging me um, with this, and she also gave me some good pointers or suggestions for these slides. Um, so the main objectives of the chalk talk. And again, I was talking about this, but talking about chalk talks through PowerPoint is kind of using iOS to talk about Androids. So I'm going to use a few slides of PowerPoint just to kind of create a framework. And then I'll open a whiteboard session where we can all talk about uh, a live small presentation that I'm going to do. Um, so the objectives are identifying the framework to develop a chalk talk and recognizing steps of delivering content, and then delivering educational content using a chalk talk format. So why or what is a chalk talk? And I really like this format mainly because it's very easy to use wherever you are. So if it's in team rounds, you can have a whiteboard installed. It's not too expensive and it's easy to use there. You can use it uh, if you are teaching on the fly. You can use it if you are inviting med students and residents to your office. You can use it very easily. Also, it is a very good environment for interactive learning. And I'll show you in the demo how it is more interactive. In the PowerPoint, it's more like a lecture format, but on the whiteboard or during a chalk talk, it is easy to kind of discuss things on the whiteboard. The other thing I felt is very important with chalk talk is when you're doing a chalk talk and when you're pausing and getting feedback, the learners can see the educators or the teacher's viewpoint or their thought process. And I always felt this, even as a learner myself, that I learned a lot when I could see how my attendings or my teachers were thinking through that process, because it really helps me like kind of see how they're using the differential the process for differential diagnosis and what medications and why. So it really helped me. And I think through the chalk talk, it is very easy to understand. And by the way, I did not know that they called this the chalk talk. I had seen this process before, where I trained at University of Alabama in Birmingham, but I didn't know it was formally called the chalk talk till one of my med students talked about when I just started as an attending here. I thought that was interesting. Now, what things do you need to do before you work on this chalk talk? Obviously, we need a small whiteboard or a big piece of paper that you can kind of write on. A good environment where it's not too much noisy. So rounding rooms are always a good opportunity. Your office, if everyone can come in and meet with you there. Knowing your audience, right? Is it the med students? Are these the residents, fellows? And the benefit of a chalk talk or this kind of teaching method is you can always have layered teaching, and I'm going to talk about it when we do the presentation or the whiteboard presentation. Thinking about learning goals, like what would the med students like from this or learn from this? What would the residents or fellows learn from this? So you can always kind of have it very layered. Selecting a topic, uh, I think with Chalk Talks, the best part is you can keep it within 15 to 20 minutes and select a topic. I'm going to talk about ADHD because I'm a child psychiatrist, it's the bread and butter. But for example, in the emergency room, you can talk about wounds or injuries. Um, uh, in neurology, you can talk about TBI, or in the hospitalist team, you can talk about kidney failure or kidney AKI and things like that. So just a few examples, and all those can be very like kind of specific and with good learning goals and objectives for each of them. So selecting a topic is important. And layer teaching and PEG system of memory are my two keywords. You'll probably hear that a lot. Uh, Layer teaching is, in the articles, they talked about different things. But for me, what my take home was, you have to have different levels. So you're building on top of things. And we'll talk about that in a minute too. So this is like your basic preparation before the chalk talk, like knowing the topic, knowing the audience, having the screen set up. And then the next subsequent steps of preparing for the chalk talk are, what clinically relevant topics do you want to use? So what I do is I have a few topics that I select, which I think that most residents, learners, fellows will like. So for example, ADHD, neurotransmitters, brain structures, which are important in psychiatry, an overview of antidepressants, antipsychotics. So those are the topics that I have in my basket. And when we see a kid who has ADHD or problems with brain injury or tuberous sclerosis or whatever it is, then I use that clinically to kind of teach that. And it's not possible to do it every day, but whenever we have time, you can do it. So topics, an outline for the talk, like pathophysiology, neurotransmitters, diagnosis, treatment. So you can have an outline for yourself. And then the headings, which are what we talked about, which can lay like a foundation for your talk. And then obviously the questions that you can use to engage the audience. And we'll talk about like what a hook is and what kind of questions you can ask to engage the audience without intimidating them. So there are different ways you can do it, but I'll talk about that in a minute too. And then the talk. So as I was saying, it's like using a hook to raise curiosity. And an example of a hook is, before I started this presentation, I was like talking about why I'm giving the chalk talk session, though I don't have a great background or experience in teaching and things like that, since I'm being an early career psychiatrist. And for your presentations, you can also use different curiosity hooks that you can engage your audience with. Open-ended questions, always learners always appreciate open-ended questions. And then how do you encourage your audience without guilt and judgment? What I do is I have, we have the med students, PA students, residents and fellows many times with us. And I try to start my questions with the medical student and then go up the ladder. And I always have like a statement which I talked about is, hey, this is not about being judgmental. It's just about making sure we are all thinking through the thought process, and I know what you're thinking and how much we need to kind of fine tune our presentation. Creating an outline and then building on it, and then topic transitions are some of the important things that happen during the talk. And we'll have a live example in some time. And then the next thing is, during the talk, using PEG system of memory. Have you all heard about the PEG system of memory? I'm sure many of us have. But the PEG system talks about having the basics and how you build on it. And this goes along with the layered teaching that I was talking about. So a good analogy would be, I have a 4-year-old and he learns the alphabet first, like A to Z, And then they teach him, or he learns about A for apple, B for ball. So you know you have a foundation, and then you kind of build on it. And then subsequently he'll be like, the apple A is red in color, the ball blue in color. So this is like the peg system. So understanding what your learners know and how you can add on to them so they kind of build up on the foundation. So that's the peg system of memory. I try to use mnemonics at times to kind of help them have that point stick. Using clinical examples is always a good way. So for example, as I said, if you see ADHD, talking about ADHD, if you see brain injury, talking about the having a chalk talk about brain injury. If you have someone with diabetes, then using that to using a clinical example and then transitioning to a chalk talk is helpful. And then they talk about, in some articles about chalk talks, they talk about the teacher learner board triad. I thought that was very interesting. I put a Google image in there. Also disclaimer, I have not used AI in any way or form in any of these presentations. So this is the teacher learner board triad. It talks about the teacher not facing the board, but standing to the side, trying to engage the learners as much as you can, asking questions and taking feedback. And even if you're writing, you can always be on the side and not to write too much on the board, just enough basics that keeps the audience interactive. And then at the end, kind of talking about, hey, what are the feedback, or what are the take-home messages or take-home lessons for each of you? So what is it for the learner, like med student? What do the fellows learn? What do the residents learn? So for having a session or having a brief few moments where you ask them about their takeaway lessons is usually helpful in kind of cementing what they've learned during the session. After the chalk talk, getting feedback from the learners, taking a picture of the board. Sadly, I did not do this a lot, but it is helpful. Some of the learners take pictures of the board, sharing it, and then definitely planning for the next time. I think those are kind of important things. So with that being said, I'm going to do a quick session on using the chalk talk, and I'm going to use the whiteboard feature. Yes. Can you all see my whiteboard?
We can, yes.
All right. So this is, I think someone is drawing on the whiteboard. So let me erase that really quick. Okay, so and this part is when I would appreciate if, and because I can't see the messages, Jan can type it in the message too, but you can unmute yourself and ask questions. This is kind of a free-flowing thing where if you all want to mimic the students or residents or fellows, everything is fine. But I'm going to start with this question. Do y'all know, or, and probably most people of us know, but do y'all know why in the traffic signal, the red light is for stop and the yellow is for go slow and green is for go?
You mean the positioning or the colors?
The color.
Red stands out more.
That's a good start.
And red starts, I mean, stop signs are red. I mean,
Yes.
I just kind of connect red to stop.
Yes.
Have to recognize that 10% of your male audience can't distinguish between red and green.
But so yeah, the red has been there for the red, like to stop, but why red? Why not yellow or green or blue? If they had historically been doing that, then I think our brains would have just associated with yellow being stop or violet being stop.
Mm-hmm.
Disney World makes a point of guests never seeing red. If you're denied admission, the admission turnstile blinks blue.
That is a good point. I didn't know that.
Yep,
So,
it was a
so
conscious decision that the guest would not see red. So if you're declined, if you try and use your magic band or your admission, material, and for some reason it's declined, the device will show blue but not red.
that's interesting.
I don't know if this is going back evolutionary, but red seems like a danger color, like
Yeah.
blood. I don't know. Something.
That's a good point. Any other guesses?
It's easily visible from a distance.
Sorry, who's that? I can't see all the names.
It's Deb. I'm one of your support staff.
Oh, nice. I think that's a really good one. It is seen from far, but do we know why? Anyways, so I was always a very curious kid growing up. I used to ask my dad all kind of questions, and he used to get really puzzled and confused. But again, going back to curiosity. So this is the prism. I'm not a good artist, but the Newton's experiment was when the light goes through the prism, the red is here and the violet is here. So violet, indigo, green, blue, yellow, orange, and then the red. So the red is the one which has it's the least refractive. It has the longest wavelength. And then the traffic signs were originally for the train drivers. They had to see the signal from far to kind of slow down and stop. The train takes longer to stop, unlike today's cars, which can brake really quick. And so they had to have the ability to see the color from far too long so that they can slow their heavy train down. And the red is the one that can be seen in fog, in rain, the farthest, because it has really long wavelength and the refraction is really, really low. So that's the reason why it's red. And again, yellow is pretty close there, and even green is close there. But the red is the one that is seen from the farthest. So I know a couple of y'all answered that correct. So again, this is a good example of a hook that you can start with your audience. This other one that I use is like, why is seawater salty? That was the first question I asked my dad when I was 9 or 10, and he was like really stumped. And remember, these were the days where there was no Google, so he went to the library, brought an encyclopedia for me and things like that. But curiosity always helps with as a good hook. So I'm going to just talk about ADHD and the examples that I use in today's presentation, because and I chose ADHD, and I'm also I'm trained in sleep medicine. I was thinking about sleep versus ADHD, but ADHD kind of mimics closely with many other health issues that we can kind of subdivide into categories. So I'm going to start with, it's hard to write with this, but it's going to use, so pathophysiology, right? So if think about this as it's not a good brain. It's going to use like really rough, crude brain structure. And then I start with my meds. So like when I use the hook question or a curiosity related question, then I subsequently will be like, see, when I asked you the question and I paused for answers, you could see the people's brains turning and you could be like, hey, I should have known this answer, or, oh, this is my guess and what's next, right? So that in itself gets your brain running. And I have read of many articles and research which shows that when you're actively participating, you learn more. So if I see a documentary on Netflix about food or colors, I'm not going to remember most of it because half of the time I might be probably zoning out, even if I'm interested. But if someone talks to me, asks me my perspective, and then I'm like, going back to the PEG system I talked about in the talks, I'll be like, I thought red is visible from far, or red is color of blood and danger. That's why red is stop. But then I'm like, no, it is the wavelength. Then you're like, huh, so probably red has the longest wavelength and blood is that color, and also the stoplight. So when you connect those, you remember things far more better than just your attending or your teacher dumping knowledge on you. So creating curiosity is always the first step. So I asked med students, and probably most of us know about this. So, and then some of the students will start like, okay, this is the frontal lobe, this is the parietal lobe, temporal lobe, occipital lobe, and so on and so forth. And then I'll be like, okay, what part of your brain is ADHD involved in? And most students answer this really well. So it's definitely the frontal lobe. And then for the residents is the next step. So again, layered teaching. Yes, frontal lobe, you're awesome, you're right. What is the next one which is involved in ADHD? And so some students will be like, yeah, it's the prefrontal cortex. So this is, frontal lobe is a little bit bigger, but it's the whole prefrontal cortex which is involved in ADHD. Good job. And then what more in the frontal lobe? There are specific areas. And that's when some of the fellows will kind of jump in. So there is it's called the dorsolateral prefrontal cortex. And then here is the ventromedial prefrontal cortex. So the dorsolateral does a lot of cognition. And again, PEG system, the D is very close to ABCD. C is for cognition, D is for dorsolateral prefrontal cortex. That's how I remember it. That's what I tell the students. That is very involved in cognition and ADHD. Then there is this is the orbitofrontal cortex right behind your orbit. We all remember the Phineas gauge experiment that is related to impulsivity part of ADHD. So in Phineas, like the guy Phineas Gage, he was laying railroads and he had an accident where the steel rod went to his brain. It's a neurology case, classic. And he became a really different person, very kind of vulgar is the word they use, where like he was talking in a very crude way before he was a very refined gentleman, is what they say. He didn't die, but he had all these behavioral issues and he died sometime after. So that's our orbitofrontal cortex, right? And then there is, this part is the anterior cingulate cortex, which does a lot of task planning. So for example, if I drove to work today and dropped coffee on myself because my cup was not completely fit, the next day, me remembering to put the cup properly or use something where I cannot spill the coffee. That is what ACC does. In ADHD, when it doesn't work properly, you will repeat the same mistake over and over again. And if it goes into hyperdrive, then you have OCD symptoms where I'll think about the coffee spilling for a month. Brain is beautiful, different parts work different ways, but it's not like a piece of puzzle, different things do differently. And again, so the fellows might be able to say some of this, but when I do this layered teaching, the residents remember some more and the fellows are reinforced of the knowledge they have, but they'll kind of gather some more. And then at the end, I'll have something that probably the fellows also don't know. This is important, but there is something called CSTC. It's called the cortical striatothalamico-cortical loop, which loops in the forebrain, midbrain together, because brain definitely is not a piece of puzzle. It is the tract system. So this tract is connected in ADHD. You'll also hear about that in depression, anxiety, OCD, everything else. Okay, this was pathophysiology, and I usually summarize it. So in pathophysiology, you see some of the brain structure that I have drawn. It's better on the white, like on the main chalkboard, but this is kind of crude. But these are the brain areas that are kind of important. Then next step. So this is the pathophysiology about neurotransmitters. And then I'll ask students, what neurotransmitters do you think are ADHD involved in? Any guesses that y'all have? So it's definitely dopamine, and dopamine has a role in different places of the brain, and then norepinephrine, which is the fight flight. Both of them play a significant role in ADHD. And so some of the med students are able to talk about it, some residents are, and then some of the fellows are. But then talking about layer teaching, what about dopamine and norepinephrine? So the consensus in literature is it's neither one or the other, increase or decrease. It's actually an imbalance between dopamine and norepinephrine, which really causes ADHD. And then like students and residents give guesses that, okay, this might be increased, that might be increased. And then you add in the final touch that you know from your experience and from your literature review that, okay, it's not the increase or decrease per se. And also this imbalance mostly in the frontal lobe circuitry is what causes ADHD. So you can use that, again, the PEG system and the layered teaching to talk about this. So this is the second subsection. And then we talk about, and I only have 4 here. So diagnosis and then treatment. You can do this outline before, like on the left side, the pathophysiology, neurotransmitters, diagnosis and treatment, or you can do it as you go. I try to do it as I go. So for diagnosis, the standards are the Vanderbilt forms. So these are the forms that you give parents and teachers because ADHD has to be diagnosed in 2 different settings, at least 6 of the symptoms for 6 months below age 12 is what the criteria is. So you can talk about the criteria, you can ask students, and then you can also ask. So some of the residents and fellows are definitely able to talk about the Vanderbilts, and then there is this Connors continuous performance test, which you can do it on a laptop. But you have to have a psychologist or someone with experience doing it and interpreting it. So these are the 2. Vanderbilts are easy. You give the teacher and parent forms, and these 2 are for kids. And for adults, there is this beautiful 1-page form called ASRS, which is Adult Symptom Rating Scale. I have seen a lot of primary care doctors give that so that they can document that, hey, I did some test and ADHD is positive, and hence I'm using the stimulants, which I think is a great idea. So then that's the diagnosis. So this is the diagnostic part. And then I ask the residents or students about the treatment. Any guesses about the treatment for ADHD? So there's definitely amphetamines, Ritalin, Concerta, or methylphenidates. Then there are amphetamines like Adderall, Vyvanse, and then Strattera. So I have a mnemonic that I used to use as a resident. So it's called MASS. So M stands for methylphenidate, A is for Adderall, Adderall salts, S is for Strattera. And then I asked them, okay, now I'll talk about more about these medications, but do you know how they work? And some of the students are able to guess, but methylphenidates are, I call them DNRIs, dopamine and norepinephrine reuptake inhibitor, similarly amphetamine too. And then Strattera is a pure NRI, norepinephrine. And look at that, we were doing a layered or classified teaching, right? Because you know that the neurotransmitters are mainly the dopamine and norepinephrine, all your medications are actually working on the dopamine and norepinephrine. So you're now connecting the dots, and that kind of emphasizes the learners to remember both. It's like, oh yeah, like that's the pathophysiology or the neurotransmitter wise, and we are using the medications which actually works on that imbalance. The methylphenidates definitely, so this is only the reuptake inhibitors. The amphetamines are not only reuptake, but also release, which kind of on paper shows that the amphetamines are stronger than the methylphenidates. And then Strattera is used when you are not tolerating the dopaminergic effect, or you are too hyperactive, or there are concerns of substance abuse, then you only use Strattera. And the methylphenidates are Ritalin, Concerta, and I can go on about that more in detail when I talk to the residents. And then for the fellows, I'll add that, okay, why do you use different medications at different times? What are the indications? And then I have a small handout which talks about like the distribution of the medications or the curves and all that stuff. So again, with layered teaching, I think it helps with teaching the med students like the basics, so they connect it, and then the residents and the fellows. And at the end, I'll ask them feedback for the medical students and for the PA students. And most of the times I get feedback that like having this simple outline on the board really helps them have a good take-home message, like, oh, the pathophysiology is this, or the neurotransmitter is this, and the diagnosis is this. And for fellows, I hear them talking about, okay, I heard or revised my basics in a succinct way, but I also had some more take-home messages. And the end thing, one of my favorite attendings in med school used to say is, if you make your learners go home and open the book about the talk that you had, then you were a brilliant teacher. It's not about, so the term education actually comes from educe in Latin, which means to bring out or to nourish. So if you're able to make the learners go home and read about the topic that you were talking about, I feel like that day I've been a successful teacher. So this is about the whiteboard. Any questions on this?
Really appreciate how the whiteboard or flip chart or whatever you're using, depending on your situation, how it adds a visual element to lock things in, and also really encourages, the interactivity when you're drawing things out and you're asking for your learners to help to build the next part of your drawing or the next part of whatever you're going to put on the whiteboard. I appreciate that additional element.
I
Any
always
other-
support multiple learning styles because I'm a visual learner too.
Absolutely. Yeah.
I really
And I
love,
think-
Dr. Reddy, that when folks are learning using this method, that they can take a snapshot at the end of that chalk talk and have all of this really important information that they can take home with them, refer back to, share it with others who may not have been able to receive the information, in that particular time frame. So I think this method is really helpful, really useful for so many different venues and different content as well.
It is super valuable. And I think also, if for those of you who are nervous about drawing or writing with the pen, on the whiteboard, you can also use shapes. There's shapes that can, really make it a lot easier to draw a circle or something along those lines. Or, and you can use the text boxes to type things out, so you don't have to worry about drawing with the pen in the whiteboard.
And again, I'm also not a good artist, and it's hard to kind of draw with this. So can I close the whiteboard? I just have one or two more slides to kind of summarize what we talked about.
Absolutely.
Close the whiteboard, and I'm going to share. Can you all see my screen again? It says
can.
example. Okay. So again, just to summarize what we talked about, and this is, I think, my understanding of what I feel about Chalk Talk. It's about an effective, some of the strategies that you can use for effective Chalk Talk are, number one, raise curiosity about the topic. So you can start with, what do you think about diabetes? Or what do you think about how kidneys work? And starting that way. And then using very clinically relevant topics or points, and engaging the audience. And I think with Chalk Talks, even if it's not clinical, it's just about teaching. You can use a Chalk Talk to help understand how do you teach better. Or if it is about leadership, or it is about improving workflow, or whatever it is, I think having this format really helps. But for clinically important topics, I think it's very helpful too. It helps us engage the audience. I think it's hard if you have a huge audience. I think you can do that if then too. But with the groups that we teach during rounds and stuff, it's very easy to use Chalk Talk to engage the audience. And again, at the end of your Chalk Talk, like having a good summary or good take-home message, like, I hope you all understood the basics of ADHD with this Chalk Talk would be like a good take-home message. I love Sherlock Holmes because he's the picture of curiosity, I guess. He was always a very curious person, like looking and learning and asking questions. And these are some of the references, a couple of them for Chalk Talks and a couple of them for ADHD. And again, I'm not a national expert in ADHD, but my information is from a couple of, like, Stahl Psychopharmacology, which is like the Bible psychopharm textbook, I feel, and then the pharmacology on amphetamines and methylphenidates. Let's stop sharing the screen, and I'm open to questions. If you all have any questions for me.
Well, it looks like Dr. Yurick has a question.
Hi, thank you very much for that. I wanted to ask if you tend to just come up with a talk chalk on the fly based on patients or conversation, or if you have a little library that you will go to and grab.
Dr. Urich, first of all, thank you for coming and joining and being so attentive. I know you have a really busy schedule
Mm,
and you handle a lot of things, so I appreciate that.
yeah,
Uh,
you're welcome.
to answer your question, I do have a library of things because when I talk and when you encourage or engage your audience, they will come up with really strong questions, which is good. I want them to be engaged. But at the same time, I want to be prepared too. And many times I do tell them, hey, I don't know everything about this topic, but so I have a bucket of topics which I feel are very important during the rotation. The fellows are there with me for 3 months, residents only 1 month, med students 1 week, sometimes PA students for 1 to 2 weeks. So I try to have the most important topics like ADHD, antidepressants, antipsychotics, autism, some other learning disabilities, sleep as a topic. And so there are a bucket of topics that I have. And then when a clinical case comes in, so for example, if somebody has really bad insomnia on the unit that we have, then I use my sleep talk. If somebody has autism, then I use very similar, like what brain structures are involved, do you think? What neurotransmitters or what areas of the brain? What is the diagnostic criteria? Can you be misdiagnosed and what treatments do we have? So I have like, to answer your question, I do have a bucket of topics that I use and I prepare well for them. And then I use them in my chalk talks. Sometimes learners do have other questions which are not in my bucket. And then I try to do it on the fly, but it's definitely not as effective if I have it well prepared and I have a layout or foundation. But I haven't had learners ask me like a general topic question because most of them are already in my bucket. It's very rare that they'll have like a question out of it. It might be a small subset question. And if they have it, so for example, like what medications do you use for ADHD? That could be a good segue. Okay, good job. Let's talk about ADHD and then you can do your chalk talk and then you have them like learn the whole thing and then they have a good perspective like, oh, that's why norepinephrine and dopamine medications are used because that's like the neurotransmitter basics of ADHD.
Excellent. I really love when we don't have all the answers as teachers, and then we can guide our learners to, here's what I would do if I didn't have the answers, which I don't. Maybe, there are lots of things that we just can't have all the answers to. So while I know it puts us all in a vulnerable spot to not have all the answers, I think a chalk talk would be fabulous for even those topics that we're not super experts in. Dr. Whitehead asked, how long do your chalk talks generally last?
So it's just like now, it's max 10 to 15 minutes. And I don't like to have them long because the longer you talk or the longer the session goes, the less people have interest. But with chalk talks, I have realized that even if it's longer, because you're engaging your audience, they're always alert and they're like, okay, what's the next question? How best can I answer it? And I always use disclaimer statements like, hey, it's okay if you don't know the answer. We are all learning. I don't know answers to everything. And sometimes when the students say, what, like, why is this? And I don't know. I was like, yeah, let's kind of look it up. Let's improve. Like I learned through your curiosity and you learn through my curiosity. So I think that's helpful. So to answer the question, I've seen like 15 minutes max, but it has lasted a little long when the questions are like related to, but in addition to the topic.
And really, it seems as if your chalk talks are complementary to something else, right? So maybe you're on rounds or something like that, and you do a chalk talk, or you have, so it may not be like, okay, we're going to have a chalk talk today. It's more complementary to something else that you're doing. Is that true?
Yeah, so I'm an inpatient attending and like on the R3 rehab, so we have our whole team there. And that's a good opportunity too, because like if I invite them for a particular time and it's not possible for them, people have different things going on and lunch lectures and other things going on. I have noon meetings too. So it's kind of hard to kind of coordinate it that way. And I have tried two different ways. I tell them, hey, let's talk about ADHD tomorrow. And then they do some preparation and I come in and it helps. Or I'll say, in this week, let's cover these two topics like autism and maybe antidepressants, or autism and maybe sleep. And then they do some basics and then we come up. But like when and the more the students are prepared, the better it is. But even if they're not, you still get to know, okay, this is this kid's basic understanding of this topic and in general, so I can fine tune my teaching even in rounds or even in general to his level of understanding. Because if I teach a student, med student at a fellow level, I think it would be a really big mismatch. They won't understand what I'm trying to say. And they'll also feel like, oh no, I don't have this much of knowledge. But if I like fine tune it to different learners' ability, I think they feel more involved and receptive. That's a feedback I get even in my, it's called the one thing with the med students feedback. They say that the chalk talks really helps because they feel that the teacher is at their level. And the same with the residents and fellows, because I think they feel very involved. And even if the students are not able to answer, when they are able to answer, they feel like they're teaching everyone. So you're having the high upper level learners involved in teaching the lower level learners too.
I love that. The glory of working in an academic health center. So also, are there guidelines? It seems like the topics that you've chosen are very discrete in nature, and sort of contained. Is that what you suggest for Chalk Talks, or would you also encourage broader topics that could go in various directions?
So when you say broader topics,
So maybe mental health as
I
opposed,
see.
you know what I
No,
mean?
so I think that would go opposite to what my, or even what the literature is talking about chalk talks. It has to be specific, because if I talk about mental health, then it includes a lot of things, and my chalk talk will become an hour long talk. And also I'll not be able to like create subheadings, which is so important to the chalk talk. So having like measurable goals and objectives for that session really helps the most. And because it's like on the rounds, like you'll have 5, 6 different patients, 7 different patients with different things going on. So you really can't have all of them together at once, and it will be very difficult. And I don't think the students will remember everything related to the whole thing. So if I do like, okay, let's do autism today. Let's learn about the brain structures and let's learn about how it affects or what's going on. They'll have a good take-home message to that. And then you do another aspect the next time. The one thing that I've noticed is sometimes you have to repeat these chalk talks if you have your fellow who's there with you longer and the students. But I try to mix it up, and to when the fellow is not there, then I'll talk about neurotransmitters, which I might have talked a couple of times with the fellow. So I'll use that with the residents and students, and so.
That's very helpful. Thank you. And Dr. Chris asked a question that I was also thinking. Do you ever have the student prepare one for the team with PBL? It seems like they would be good at that. And I bet yours are so well received due to that.
So I have tried it a couple of times. With one of my fellows, I I talked to them about doing a chalk talk. I think it was with one of the antidepressants, and they did a really good job. But obviously, I felt like I had more practice doing it, so I could do it well. And also, different learners might feel it differently when you're the encouragement about questions and being non-judgmental. Different people do it differently. Like I was doing it with when Dr. Harrent was present, and she felt that my questions were kind of like non-judgmental and very encouraging. Not everyone might do it that way, but if I had enough time, or if I'm training someone to do chalk talks, then I can definitely kind of lay guidelines like, hey, this is how you can involve people and ask them questions without them feeling, hey, this guy was asking me questions. And I think it just comes with experience and practice. And like where I trained, they used to do a lot of chalk talks without officially calling it that. And so I really liked it when some of the attendings did it, and I kind of inculcated it. And I think it's come that way. But to Dr. Chris's question, yes, if we kind of let the students know or give them a chalk talk about how to do chalk talks, and then they can use that to kind of teach other residents and students. And some of my fellows have done it and they do it really well, but they may not use the exact format that I use. They might not do it that efficiently, but they do a good job. And even without chalk talks, I think some of my fellows teach residents and students just a small topic, not using the whiteboard, just discussing things. But I like to use the whiteboard that I have in my rounds room to kind of talk about these things. I should have taken a picture of that, but
All right, next time. I do think it would be a great opportunity to, it's so practical and really generalizable to pass on to our learners as ways that they can use to teach, and just share with them the core guidelines. Like, it's got to be very non-judgmental. It's got to be brief, very discreet, those types of things. And I think they would do well with that. I love that you're doing this. What other questions do we have for Dr. Reddy? Dr. Yurek?
I have one kind of general chalk talk that I give in various formats that I thought maybe I would just share. And I think I'm calling it a chalk talk, but you can tell me if it is or isn't. But oftentimes we'll make a line, and when we're talking about a diagnosis, let's just say strep throat, and the line is from 0 to 100, and I ask the student to tell me where on the line after they saw the patient, what is their percent chance they think this patient has strep? And let's just say they say 50. And then we talk about what they need to do to move up or down. And that gives me a chance to teach them then about the Centaur criteria, and to teach them about the sensitivity and specificity of our rapid strep testing and cultures and things like that. Appendicitis is another really good one. You can say, okay, you're 20%, not good enough. Can't go home, can't go to the OR with 20%. You got to move up and down. And obviously that works well in the ER with an undifferentiated patient, but I just thought I'd say it out loud because I find it helps me have a more on the fly chalk talk, because that's all knowledge. We all know how we move on that pretest probability line. Anyway, don't know if you have any thoughts on that, or if that could be considered a chalk talk, or if it needs more structure.
Dr. Yurek, I'm not an expert in chalk talk. Anyways, that's my disclaimer. But I feel like from my view of things, if I was a student of yours, I would really like it, because two things. Number one, just by drawing the line and asking about probability, you have increased my curiosity. And I'm now thinking, oh, like where in this line, how correct am I? How wrong am I? And again, you have not created any judgment there by saying, or obviously you're saying like, tell me, what do you think? So that's definitely a non-judgmental statement. So I'm gonna kind of thinking about it. So that raises my curiosity and my participation. And then when you put it on a spectrum like that, and if I'm thinking it right, you're also teaching other things like, okay, these are the symptoms which are not very important, or these are the symptoms which are definitely like red flags. So I think that gives some take home messages. And after you talked about it, I'll definitely go home and read the standard textbook about, okay, what are the symptoms, what is causing it. So I think you hit all the right buttons there to help like students participate more in that and be curious about it.
Other questions, comments, concerns?
I have a quick question for you, Dr. Reddy. This is Sarah Harrent. In the literature that you've read concerning chalk talks, is there anything that you would give as suggestions for somebody who maybe has not used this as a technique? Are there like some guidance that folks could fall back on beyond the great talk you've given today, so that if they wanted to learn more about Chalk Talks, wanted to get more engaged in this method, or maybe they just haven't used this in a while and want to brush up on using this as a teaching method, that you could point folks to.
So I had the two references I have are the ones that I have used, and I think those are similar ones that you like forwarded to me when we were talking about Chalk Talks. The one in both of them, what I felt was helpful was about the backdrop or like an outline, but also felt that some of them were too detailed. Like they were talking about like drawing or writing the whole thing on the board, which I feel is, especially for like clinical educators, it's going to be pretty hard to write the whole thing. Like I won't be having time to draw the whole brain and all the structures to talk about like ADHD. Yes, I'm going to draw an outline and draw the basics, which are important. And I'm not going to talk about the whole neurotransmitter dopamine dysfunction and talk about the whole thing. I think they were talking about writing a little bit more, but for me, I felt like clinically it's more relevant if I'm like talking about the outline and raising curiosity in my Chalk Talk, so that I'm giving you the take home message, but I'm also letting you know that for further detailed knowledge, you need to go home and read, because I'm not going to be the one who's going to dump this knowledge. My goal is education, which is just to increase your um, curiosity and bring out your willingness to learn about this topic. So that's where I agreed with the outlines and stuff in those articles. It's in my references slide, but also I did not think that I need to write a lot on the board. I also agree with standing on the side of the board, facing, that's what we do, facing the learners, engaging the learners, but not following everything in those references. And I feel like you definitely need to fine tune it, just like Dr. Urek is doing, is like her format is using a spectrum scale. Other people might fine tune it to their effort, and obviously listening to the feedback of the learners. If they're like writing feedback consistently that this helps or this does not help, and thankfully, like most people have said that this format helps them, so that's good. But even if in verbal feedback, if they say, hey, I would want to learn more about this or that, so you can kind of include it. But yeah, as Dr. Hammond was saying, the references were helpful, but I personally have fine-tuned it to, and even before reading them, I was doing that. But after I read through the references, I felt, yeah, I follow these things, but I don't necessarily agree with these other things that, and I think what, like both those articles are by physicians who do round Chalk Talks or like Chalk Talk on the fly kind of thing. So because in one of the examples, it's actually acute kidney failure is an example that he like uses on that thing. So, but I think it was more in detail than what I would do in terms of like putting things on the board.
Thank you so much. This was a wonderful talk, very helpful, very practical. Dr. Urich also put in the chat, if you're a Carilion Clinic physician or faculty member in HSIS or DBSE, please take 5 minutes to complete the well-being and burnout survey that came out today. It's anonymous, and we vow to use it to improve our system and culture. So please remember to do that. I hope you all have a wonderful day. Take care of yourselves, and we'll see y'all soon.